Yes, sir. Visible, sir.
Okay, okay. Now, good evening, everyone. Now, I have the topic given to me today is to the fever, approach to fever. Okay, approach febrile illness, or some clinical importance, the examination in the fever, or whatever it is regarding fever. So, I have put it as a white arm fever. Okay, fine. Now, I'll be briefly discussing, unlike the other previous approaches, I'm not giving you the cases to discuss right now. But I do have some cases. If the time permits, I will discuss some cases, the hypothetical cases. Now, currently, I will describe briefly about fever. I'm sure that every one of us had fever one or other time, at least once in a year, twice in a year. At least I do get fever once in a year or twice in a year. Hope with everyone. That is normal response, isn't it? So fever is not a disease per se. Fever is just a symptom of multiple hundreds of problems. Okay. Now, whenever we get, of course, for every OPD or every doctor, the commonest presentation will be for the fever or some pain. So fever and pain are the common presentation for a general practitioner or even a physician practitioner, wherever it is. Unless it is a very marginalized or super specialist. Otherwise, a generalist and a family physician, fever and pain will be the commonest. So we should know the ABCD or everything of the fever, A to Z of the fever. So we will go step by step. Now, what is fever? It is just abnormal. It is defined as abnormal elevation of the body temperature above the normal. So we know that normal, there is some variation. However, 99.6 degree Fahrenheit or 38 degrees centigrade, we define it as fever. Now, or any temperature above the set point of the thermoregulation. Thermoregulation set point. We cannot record the thermoregulation set point. Okay, so then that is very difficult to define what is that set point. Fine. So now the fever, maybe the patient may come to you with fever of 1 day duration, 2 day duration, 1 week duration, or sometimes even months together fever also. So whenever the first approach patient says that I have some fever, we need to find out the duration. Like any other history, what is the duration? Now, if the fever is of less than 2 weeks duration, we call it as a acute febrile illness. Recent onset febrile illness, so acute febrile illness. If the fever of more than 2 weeks without any diagnosis, it may be long-standing febrile illness without diagnosis, or with some diagnosis, it doesn't matter. Okay, if fever of more than 2 weeks, 2 to 3 weeks duration without appropriate diagnosis, in spite of investigation, we call it as pyrexia of unknown origin. We are not talking about that right now. We are talking about acute fever in day-to-day practice or in your clinical practice or your when you talk to the patient for the evaluation of febrile patient. Okay. Now, there are so many conditions which can produce fever. Of them, the commonest, the 80% of the time, fever is due to the one or other infection. Okay. It is not the infection alone. Many times we may go wrong. There may be some inflammatory, non-infectious inflammatory disease, like somebody would have a trauma, polytrauma, or a recent surgery, or somebody who got some inflammatory bowel disease. Something like some inflammatory process going on inside the body can generate fever. I will tell you how do they develop fever. Of course, all of you are aware of that. I'm just revisioning the physiology and other things, revising the physiology. Okay. Then, small quantity of people, small percent of people, maybe around 5 to 10% of people in appropriate setting, simply connective tissue disorders or vasculitis, connective tissue disorders manifest as fever. In about another 10% of people, tumor may be the cause, underlying disease manifesting as fever. So fever is not a single disease. Fever is a manifestation of so many wide categories of disease. Out of them, each one have got hundreds of ramifications. There are hundreds of causes under each one. Okay, fine. So it is and hardly 1 to 2%, or say up to 5%, we may not be able to identify the exact reason for the fever. Okay, sometimes it may not be diagnosed. The reason for the fever may not be found out at all. Hope I'm audible. Okay. Yes. Now, now I'm talking about fever of less than 2 weeks and probably the infectious cause. I'm not dealing with the inflammation, connective disease disorders, tumors and other things. We will just understand what are the different possibilities. Then we'll go further. Now, if the fever is due to definite infection, once the fever is there is something infection, if it is there. Now, previously we used to define it as sepsis. Now there are so many other, I will come back to that. Now, if the infection is there, now we need to decide whether it is acute infection or chronic infection. Okay. Now, whether it is acute or chronic, that depends upon the duration of the illness. Usually for the febrile illness, less than 2 weeks is acute one. More than 6 weeks is a chronic one, and in between is subacute or something like that. Whether it is acute infection or chronic infection, we know that the infection producing organisms, it may be virus, most common thing right now. It may be bacterial, otherwise also it's common. Parasites like malaria, rickettsia, or fungus. All these, the pathogens, sometimes even when the immunity goes down, even commensals can produce the fever. Okay, infections. So we need to understand that these are the common pathogens. I'm not talking about the details of this thing. These are the broad varieties of the pathogens which can induce infection and thereby fever. Okay, fine. Of them. Now we know that whenever we talk to the patient, if a febrile patient has got some respiratory symptom, cardinal symptom of respiration is there, like fever with the cough, breathlessness, expectoration, something like that, we know that this infection is occurring in the respiratory system. Similarly, if the patient comes with a dysuria, frequency of urine, burning micturition, frequency of micturition, and fever, we know that this infection or the pathogen is causing problem in the urinary tract. Similarly, there are so many things. Now, when such symptoms are there, we call them that fever with a focused infection or systemic infection or localized infection. They are localized to one system. Now, many a time, when the infection starts in our body, the fever is a response to the invading organism or some other things. We'll come back to that physiology later. Now, we will, many of time, in the first week, we may not be able to identify what system is in which system is infected. What is infecting? We will not be able to identify. In such a condition, we call it as undifferentiated fever. That is usually the first 3 days to 1 week. Fever is there. We know that it may be infection, but we are unable to clinically detect that whether it is viral infection, whether it is bacterial infection or parasitic infection. We are not able to differentiate. And there are no system is identified. No system is, the symptoms are not pointing in a particular system, GI system or respiratory system. In such condition, we call it as undifferentiated fever. As per the WHO, not in our place, all over the world, the commonest cause for the 70% of the acute undifferentiated fevers are due to malaria and dengue put together. You get my point? So when you get undifferentiated fever, these are the two things should go to our mind first. But now, in the current scenario, as per the WHO, anyone who has got fever of less than 10 days duration with the cough, cold, so-called influenza-like illness, we should suspect possibility of COVID. Okay, fine. Now this is what? Now this is not the great slide. I have just copied from the your Davidson, the current edition. Now that says that common infectious syndromes presenting with the localized feature, patient has got fever and localized feature. Now we know that there are so many soft tissue is there right from this corner, soft tissues involved. We know that it may be cellulitis or furunculosis or osteomyelitis, depending upon the soft tissue or the bone which is involved, that can manifest as fever. We know that there is a local sign. Patient himself says that I have pain and swelling at a particular point. So we need not worry about what could be the cause. We only need to find out what is the pathogen, what is the underlying defect there. Okay. Similarly, patient may come with abdominal pain, vomiting, diarrhea. We know that it is a GI system is involved, or right hypochondriac pain, or patient may be having concurrent joint disease. We know the liver is involved, something like that. So we have various things which are focused. Patient who have got fever, altered sensorium or seizures, we know that brain is involved. Similarly, respiratory system, sinusitis or pharyngitis, tonsillitis, so on. We have every system. Now they are all fever with the localizing feature. So we do not have much problem identifying what is the focus. Fine. Anyway, we'll evaluate how to go by each one. Now, before going further now, we will just understand what is body temperature. Now, the humans are warm-blooded. We are all warm-blooded. That means our body temperature is maintained at around 36 to 37 degree Fahrenheit with a very narrow range of normal body temperature, the core temperature. Okay. Now, we need to understand that the normal body temperature varies from part to part. From the lower end of the esophagus, that is so-called core temperature, or the rectal temperature, or under surface of the liver, these are all the places called as core temperature. Our temperatures on the skin is always lower than the internal temperature, core temperature. Okay. Now, 36.5 to 37.5 degree Fahrenheit centigrade or 97.7 to 99.5 degree Fahrenheit are normal core temperature. Now, oral temperature is slightly lesser than 0.4 to 0.6 degree Fahrenheit centigrade, less than the core temperature. So, oral temperature almost correlates. But skin temperature or axillary temperature are always 1 degree Fahrenheit less than the oral temperature. Okay. So there is a difference. So now we record non-contact thermometer. Okay. Now that takes to the cutaneous temperature. Similarly, somebody may record from the what are that eardrum. That is also not very. Those are all not a true recording of temperature. They do some calculations, modifications, and they correspond. The value which is shown in the thermometer, the digital thermometer may be modified one. Okay. So if the computer chip is not fine, it may give erroneous report as well. Okay. Now there is a diurnal variation. Even day-to-day normal, there is a diurnal variation. The body temperature, core temperature, lowest at the 6 a.m. and highest at 6 p.m. The difference is almost 1 degree Fahrenheit. Okay, fine. So typically, to be called as fever, morning temperature, even if it is more than 98.9 degree Fahrenheit, it has to be called as fever. Whereas evening temperature, if it is more than 99.9 degree, we call it as fever. But in general, if it is more than 100 degree Fahrenheit, we consider it as fever. That is a common thing. Just by 98.4 degree Fahrenheit and it's more, we generally doesn't call it as fever. Okay, fine. Now, there may be physiological variation. Various subsets of people, there may be physiological variation, especially in the women. Okay. Ovulatory cycle, because of the hormonal imbalance, hormonal changes, normal hormonal things, from the day of ovulation till the menstrual cycle, that 14 days, 2 weeks of thing, their body temperature, both in the morning and evening hours, their body temperatures are slightly elevated, up to the 1 degree Fahrenheit, up to, not 100%, 1%, maybe up to. So they may have feverish feelings many a time. Immediately after food, everyone, we know that both the metabolic rate increases, heat production is more, we may be having feverish feeling, or if you record temperature, maybe a little more. The patient may not feel, but we all have learned about SDA, and we get sweating after heavy prandial state. So that may be slight elevation in the body temperature. Even in pregnancy, there may be slight elevation. Those are normal physiological temperature. And after exertion, it may not be fever, but it's just post-exertional elevation in temperature. Okay. Many times now I have noted now in the current state, every person who comes to the hospital are screened with the temperature. Now they say that I do not have fever. They would have walked in the hot sun and their temperature is going up to 38 degree Fahrenheit, centigrade. So that may be because of the current trend. Exertion plus heat. Okay. Now, we'll go a little further. We need to feel the warmth and cold sensation of our body. What are these? receptors which tells us that there are cold and warm sensation. We all know from the physiology, the lower the figure there, the crochet end bulbs, which are situated in the just beneath the epidermis, not in the dermis, beneath the epidermis, little deeper, just above between the subcutaneous tissue and epidermis. There are these, so there are little deeper structure. So we don't feel the cold as early as the heat. Whereas the heat sensation, the thermal sensation, the hot sensation are sensed by the Ruffini and organs. They are very superficial, the epidermis. So very superficial in the dermis and the epidermal layer. So they are the hot sensation is felt very early for us. Okay. Now, what happens when these organs, when these the receptors tells us that our body temperature is the cold or whatever is increased, that gives a signal to the thalamus. Okay, that is one way. The second way, the core temperature, when it goes up, the blood, the temperature of the blood is also increasing. Okay, now we all know that the thermoregulatory center in our body is the hypothalamus grossly, but the sensation of these receptors of the increased core temperature or the blood temperature is in the pre-optic nuclei of the hypothalamus. That is the anterior part of the hypothalamus. Now, that is in the blood bath. Surrounding that pre-optic nucleus or the hypothalamus, there are plenty of blood vessels, capillaries. So whenever the blood temperature goes up, that senses and that gives the efferent, to the various tissues. Okay, now that differs, the efferent differs whether to conserve the heat or lose the heat. I will come back to that. Now, so that is about the thermoregulatory center and the receptor interaction. Okay, now thermogenesis, even though temperature, the external temperature is at 18 degrees centigrade or sometimes minus degrees, our body has to maintain good amount of, maintain the narrow range of normal temperature. Okay, or even if the temperature is at 50 degrees, currently in Rajasthan, somebody yesterday it was 50 degrees, 45 degrees, our body temperature has to maintain at 38, 37 to 37 plus or minus degree Fahrenheit, centigrade, isn't it? So that mechanism is done by the hypothalamus, that internal maintenance. So that is why it's called hypothalamus, the thermoregulatory center. Now, how the body produces heat. Now, we all know that the metabolism takes place, the energy utilization and metabolism takes place in our every cell. So cellular metabolism generates heat. The maximum number of heat generation, the heat generation is happening inside the skeletal muscle tissue, skeletal muscle, the metabolism inside the skeletal muscle. Okay. Now, once the heat is produced, that is being conducted into the various tissues, various parts of the tissue, various tissues of the body, including blood. Now, when the heat, when the external environment is cold, we may feel the cold sensation because of the receptors. Now, what the body has to do, it has to generate more heat, has to be generated. Now, this is how now whenever the internal body, like as I said, whenever we exert more or whenever we develop fever or due to some reason, I'll tell you the mechanism. Whenever we develop fever or increase core temperature, the hypothalamus senses that immediately, including the periphery, and every part senses it, especially hypothalamus, by the blood bath around the hypothalamus. Then it gives the efferent to the various tissues to generate heat, as well as whatever the heat is produced, it has to go out of the body, isn't it? Normally, the heat has to exchange. Now that is called as heat dissipation or heat evaporation. That can go just by evaporation along with the sweating. Heat can go out from the evaporation from the skin. Now, how does the heat goes out? From the cutaneous tissues vessels, the cutaneous vessels, the capillaries which are spread all over the skin is circulating the hot blood, and that is from there the heat is evaporating either through the sweating, dissipation, or by the conduction, or by radiation. Now, direct radiation, emission of the heat can happen to the environment. Now, these mechanisms depends upon the external temperature. If the external temperature is more than the body temperature, or body temperature 38 degree Fahrenheit, centigrade, and your environment is around 45, how can the heat evaporate from your body to out? It cannot evaporate, it will come in. So your body develops more and more temperature. So there is conduction of the heat can go from the environment to the body. That is why in hot environment, heat stroke and heat exhaustion occurs. The body temperature goes up. Okay. Now, there are so many other fallacies in that. I will come to that. Now, you need to understand that thermogenesis, body can generate heat by metabolism. In demand, in the time of demand, body can increase the heat production by producing muscle contraction in the form of shivering. Okay. Now, and the heat evaporation can be prevented by the peripheral vasoconstriction. That is what hypothalamus does. That gives the efferent autonomous system and makes the peripheral vasoconstriction. Thereby, the blood circulation to the skin and cutaneous tissue becomes less. And there is a difference between the body surface temperature and the external temperature. So you apparently feel that you are feeling cold in spite of your body temperature is high. Now, you feel the difference of temperature, feel it as cold. And immediately that also gives the more skeletal muscle action in the form of shivering, generates more metabolism inside the muscle, entire skeletal muscle, shivering, and it produces more and more heat. There are two things that are happening: increased metabolism, decrease heat depreciation, core body temperature goes up. Okay. Now, why did it go up? Because the thermoregulator center, which is equivalent to the thermostat of your air conditioner, which can be set at 20, 22, 24, 26. Similarly, the hypothalamus has sensed that there is abnormality. We need to regulate the body heat. Thereby, the hypothalamic thermostatic center is set at either high or low level, depending upon the requirement, whether heat has to be conserved, or heat has to be produced and conserved, or heat has to be evaporated or dissipated. So that is the mechanism called as thermoregulation. Now, for this thermoregulation to happen, we should have the intactness of the hypothalamus that should function well. We should have adequate blood circulation. For that, your cardiovascular volume and cardiovascular system should be perfectly fine. You should have the intactness of the autonomic nervous system. You should have the appropriate external environment as well. All these things are required to maintain normal thermoregulation of the body. It is not a very complex system, very simple system. Whenever that is depicted, whenever the body experiences cold, heat sensor, that is hypothalamus, senses it. It gives message to the muscle to produce shivering and heat production. Body warms up. At the same time, it also gives the signal to the peripheral skin, cutaneous vessels to conserve the heat. On the other hand, the exactly opposite thing happens to the body. So heat goes out by the dissipation, sweating, radiation, conduction, everything. But this conduction, radiation does not work when the external environment is not conducive. When the humidity, even the sweating can be stopped when the humidity, external environment humidity is more than 75%. So that's all the environment. So there are so many interplay in thermoregulations. Okay, now that is the basis. Then, why does the fever develops? That is, there's something called as pyrogens. Now we were talking about there are so many conditions can produce fever. Infection is not our infection by the organism, microorganism is not derived from our body. It has come from the outside, like virus, bacteria, they are toxins. Okay, now all of them becomes external pyrogens. All of them have got capacity to induce some cascades in the cytokine inflammatory system, and they can induce thermostat, abnormal. I will come back to that again. Now, sometimes inflammatory cells, there is no inflammation like in inflammatory bowel disease or connective tissue disorder or tumors. Your immune system is producing various cytokines, interleukins, especially IL-1 and IL-6, tumor necrosis factor. All of them can affect on the hypothalamus. Now, they are called as internal and external pyrogens. Okay. Now, in addition to that, now how do these cytokines, or how do these internal or external pyrogens alter the thermostat in the hypothalamus? Now, they mediate via COX system, cyclooxygen system. Okay, the prostaglandin system. The prostaglandin E2 has got positive effect on the hypothalamic thermostat and negative, okay, and vice versa. So, by the cytokines, they stimulate the prostacyclin of PGE2, thereby they alter on the hypothalamic thermostat. Sometimes drugs, like your serotonergic drugs or some your antidepressant drugs, centrally acting drugs, they may alter the thermostat. They may alter the thermoregulate center. Now, that is not in the ambit of the thermoregulation or fever. Okay. So, these are in brief about thermoregulation. If there are any doubts or questions, you can post it on the what is that? Your chat box. We will look into that. Then, going further, okay. Now, having said about the various mechanisms of fever regulation, now we record a patient approach to us. Now, how do you record the body temperature? There are different methods. All of you know about this. However, you can use the mercury thermometer, which is ideally not to be used because of the mercury, which causes environment damage. But that is the standard equipment to use the thermometer. And you should record the temperature in the oral thermometer. That too, you should make sure that the oral thermometer is sterile. You have made it, because you'll be using it to different patients. You should be sterile, appropriately sterilize the equipment. Make sure that you know how to look for the mercury column across the recordings there. Make sure that mercury columns is set well below the normal and it's dry. And other requisite is that patients should not have consumed hot beverages like hot coffee, hot tea, hot water, at least 10 minutes before the recording of temperature, or even cold beverages for that matter. Okay. Now, place the thermometer on the under surface of the tongue. Those are the thermal point, base of the tongue. They're called as heat points. Those are where you have to place it for at least 1 complete minute, and take out and see how much the mercury column has gone up. Now, why is that? The temperature sensitivity of mercury is very low. Thermal point of the mercury is very low. That's why mercury is used. Or you can use the infrared thermometer. I've told you that whatever they record, ideally you should record in the temple. There are some thermometers in the pediatrics. You can also use the eardrum. You can use the oral cavity, other skin also. But for the normal body temperature, we use these thermometers. These electron thermometers are recording should be done at the temple. Okay, that is adjusted to the core temperature. That can give the temperature within a fraction of a second. Now, there's so many other methods to non-contact thermometers and contact thermometers. There are so many things are available, but they are not standardized. Now, if you use the mercury thermometer or digital thermometer in the axilla, mind that always they give 1 degree less than the oral temperature. Now, you have a patient of fever, or you have asked the patient to record the temperature every fourth hourly, or whenever they develop fever, at least 3 to 4 times a day, and whenever they develop fever, make the precondition very clear, and patient has not consumed any antipyretic or anti-inflammatory drug. Patient should not have consumed any antipyretic drug, anti-inflammatory drug. Patient should have been recorded, monitored on temperature every fourth hourly or at least 3 times a day. Then you can look for you can tell about the types of fever. These are typically not symptoms. Patient feels febrile. Patient says that I am feeling febrile or I have fever, and it comes sometimes of the day or present through the day. That's all you can say. They cannot say the typical patterns of the fever. Okay, I'll come back to that. Now there is one graph. I have depicted one graph. Now this particular patient has got fever at from the beginning. It was so where the first recording was at 100 degree, then 101.4, so it keeps on fluctuating. To see the over 24 hours, several recording has been done. Either it's continuous or several recording has been done, and the patient had fever throughout the day in the given 24 hours above the baseline. And the fluctuation to the highest and lowest point of fever was not more than 1 degree Fahrenheit. Now, if you have such a documentation, you can call it as continuous fever. Otherwise, you cannot document because there are so many set patterns. The temperature should be it should be above baseline throughout 24 hours. And the fluctuation should not be more than 1 degree Fahrenheit. We know that even diurnal fluctuation at 1 degree Fahrenheit. So it should not be more than diurnal variation, and should present throughout the day, 24 hours. Then only you can call it continuous fever. But most of our patients would not have done this. So appropriately in the history, you cannot mention that patient had continuous fever. You can only, because continuous fever is a technical term. It's a sign which has got all these features. So you can only say that, sir, my patient has got fever throughout the day. He feels that he is febrile throughout the day, but he has not recorded the temperature fourth hourly to say that it's continuous fever. So you can say that. Okay. We have one more patient. See this. In the given 24 hours, in the same 24 hours period, in the fever given 24 hours, fever has gone up above the baseline, and after 4 hours or 5 hours, it has come down below the baseline. It has become to normal, and again after 12 hours, it has gone up, and again it has come down. So this is the pattern very typically called as intermittent fever. In other words, you have to comment, you have to tell that my patient got intermittent fever only when the patient has documented temperature by thermometer without interference by the anti-febrile or antipyretic drugs. And they have documented that the fever temperature has gone above the baseline and it has come to the baseline within the given 24 hours. It did not go 3 to 4 times. Once it has gone up and it has come within the 24 hours, it has touched the baseline. Then you can call it as intermittent fever. In the clinical practice, while taking the history, you can only say that patient says that patient feels feverishness for a few hours of the day. The rest of the hours of the day, he is comfortable. That is the way to take the history of the intermittent fever, because intermittent fever is again a technical term. Now the next pattern, the fever has gone up, but it has never touched the baseline in the 24 hours, but the fluctuation is more than 1 degree Fahrenheit. Now this pattern is called as remittent fever. Again, to tell remittent fever, there should be documentation. Without that, you can only say that patient got fever throughout the day, but he gets more feverish feeling sometimes of the day. Those are all the things. Okay. Now, even though you document that there is no set pattern, even though you have documented that initially he gets fever only few hours of the day, we assume that it is a once daily fever, called as that fever is called as once in 24 hours, fever goes up, comes back to normal. Again, he is afebrile. Again, next day he goes up and comes. That pattern is called as quotidian fever. Intermittent fever going up only once per day. Intermittent fever only once week per day is called as quotidian fever. Now, after few days, the same quotidian fever may become regularized or synchronized to the internal pathogens. Especially I'm talking about parasite. Now, if it comes once in a day, okay, now it is called as quotidian fever. If it comes once in 48 hours, alternate days, first day, few hours of the fever, rest next 48 hours, he doesn't have fever. Next again, fever for few hours. They call it tertian fever, very classical in the malaria, especially Pathophysiology vivax, even in ovale. Okay. Now, if the fever presents once in 3 days, after 2 days gap, once in 72 hours, that is called as cotton. These are the different patterns now in the era of antipyretic drugs. Even every household will have a dolo or crocin or paracetamol. So the moment fever comes, they will take the tablet. They say that fever is reduced, and they don't take tablet after 2 days, and you again fever comes. Do you call it a tertiary fever or tertiary fever, quarter fever? No, because they have intervened with the tablet, paracetamol or something else. So we cannot talk about that. These patterns are said only when the patient is not interfered with the drugs. Hope I'm clear about that. Now, some people may be having fever for days together, maybe relapsing, maybe remittent or intermittent, whatever it is, several days in a course, continuous fever, maybe for weeks together, 3-4 weeks or 1 week, then next 1 week or 2 weeks they will not have fever. Again, they will have fever for 1 or 2 days. That is called as relapsing fever. There is one more name for that. If the fever present for 2 weeks and goes off again, now this relapsing fever, now how does it look like? Undulating. So it is also called as undulant fever or saddleback fever. It looks like a saddleback, isn't it? It is very typical Mediterranean fever. That is why they are called as relapsing fever, saddleback fever, Mediterranean fever, all those patterns are same thing. Now, if the fever present for, it may be intermittent fever, present for 1 or 2 weeks, then 1 to 2 or 3 weeks, there is no fever. Again, it comes intermittent fever. Now, that is called as Epstein fever, very typical lymphomas. Okay. Now, it is not important only to find out what is the pattern of fever. Now, we also should know how does the fever recede, body temperature recedes. Now, we know that our thermostat is set, it controls the temperature. Once it is controlled temperature, it again comes back to normal. That means thermostat is functioning to maintain the core body temperature in a normal range, narrow normal range. Thermostat functioning fine. Okay. So after a few hours, the temperature has to come down. If it comes down gradually, that is called as temperature difference by the lysis. Slowly, gradually. That is the importance. That means the body took longer hours to control the body temperature. That means there is ongoing pyrogens. Ongoing continuous pyrogens are being produced. Most commonly like bacterial infection, like your staphylococcal infection, and even typhoid infection, enteric fevers, they all will have the gradual reduction of fever. Of course, again, that reduction of fever depends upon whether you are interfered by the antipyretic. The moment you give antipyretic, like paracetamol or the metformin or NSAID, ibuprofen, they all block the prostaglandin, COX-2 inhibition in the central nervous system. They block that. So the pyrogenic capacity goes down. It is blocked, inhibited. Temperature comes down very rapidly. That is why immediately after taking the paracetamol or ibuprofen or nimesulide or metformin, mefenamic acid, the fever comes down by crisis. So we need to know that also. Fine. So there are so many types of fever: continuous fever, remittent fever, intermittent fever, tertian fever, quartan fever, Epstein fever, saddleback. So many things are there, but they're all technical terms. When the patient is not using medications, when patient is recording temperature very frequently, at least 3-4 times a day, then only you can talk about these technical terms. But they are all very fond questions. What are the causes for the continuous fever? What are the causes for remittent fever? What is fever different by lysis, crisis? All those things are common questions. Okay, fine. Now, it is not enough if you know only about temperature. Now, fever is a vital sign. Temperature is a vital sign. Similarly, physiologically, we know that when the temperature is going up, the body metabolism is going up. That is a thermogenesis. By increasing body metabolism, to produce increased body metabolism, your cardiovascular system has to work more faster, has to put more effort. Similarly, respiratory system also has to compensate, to cooperate with the cardiovascular system. Respiratory system also has to get more. So those are all the physiological companions to the body temperature. Okay. So apparently, for every 1 degree raise in body temperature, your pulse rate, that is heart rate, increases by the 10 beats per minute. And respiratory rate goes up by 4 cycles per minute. If so, your normal body temperature is 99 degree Fahrenheit, 98 degree Fahrenheit, has reached 101 degree. Your temperature gone by the 3 degree Fahrenheit. That means your resting heart prior to the fever, if your heart rate was 70 to 80, apparently appropriate for that raise in the body temperature, heart rate has to raise by 30 beats per minute. For 101 degree Fahrenheit, heart rate has to be around 110. That is appropriate response, physiological response for the raise in body temperature. Heart rate response, physiological heart rate response or pulse rate response for the raise in 1 degree Fahrenheit. At the same time, respiratory should be around 20. Normally 16, around 16. So it should be around 20. That is appropriate respiratory. If not, suppose patient has got fever of 102, we anticipate heart rate of 120, 130 range. But his heart rate is around 101, 102, 105. It is not reached it is not bradycardia. It is not reached the anticipated level of physiological response. Then we call it as relative bradycardia. We need to note about that. Is the fever and heart rate and respiratory rate are corresponding? Their responses equal, corresponding or not? If not, it is less responding. We call it as relative bradycardia. There are specific conditions which could produce fever and relative bradycardia. One second. So there are specific conditions like for the relative bradycardia. I will come back to that chat box right now after this slide. Condition producing relative bradycardia on typhoid fever. Typically, meningitis, you know that whenever the intracranial pressure goes up, they will develop reflex bradycardia, Cushing's reflex. Meningitis, even though they have very significant illness, they may have fever, they will have bradycardia. To the extent that it may be true bradycardia as well as. Other conditions like brucellosis, leptospirosis, various drug fever, some of the viral fevers, all of them will have relative bradycardia. Very common font viva question. Then, sometimes heart rate may go extremely high. Temperature may be 101 degree Fahrenheit. Very common condition now. Heart rate may be 101 degree Fahrenheit. Heart rate may go to 140, 150. Now, that is when we need to suspect viral fever, some of the viral fevers, especially in COVID, and myocarditis, endocarditis, specifically rheumatic fever. Rheumatic fever, you know, we have talked about so much about rheumatic fever. And any person who has got fever with impending shock, in all these conditions, the heart rate may go up very extremely high. Especially don't forget about, because if you miss this relative tachycardia, all these are very serious condition. Even if you miss relative tachycardia, nothing will happen, day 1 or day 2. If you miss relative tachycardia, temperature 102, heart rate going up to 120, 130, 140, you do not suspect myocarditis or endocarditis or pericarditis, you're going to miss the patient going to hypotension shock in a short time and you're going to lose this patient. So you should be extra cautious on that. I'll come back to the chat box first. Sir, while taking history, if we come to know that patient has taken the antipyretic, how do we rule out the cause for the provisional diagnosis? Now that is what you have to elaborate. You need to take that, sir, patient has taken the antipyretic, patient's fever has come down only with the antipyretic. I cannot comment on the pattern of the fever. Patient has got fever. Whenever he takes the tablet, it comes down. But within few hours, when the tablet effect goes off within 5-6 hours, we know that half-life of the drug, it only few hours. So again, fever appears. So we need to assume that it may be continuous fever. Okay, so we cannot talk about that. Okay. Now, go further. Now, once we know that a patient has got come with the fever, and we have noted other physiological responses, blood pressure, respiratory rate, pulse rate, all those things, we need to give a keen importance to that for every patient with the fever, because fever with the impending shock, you need to resuscitate, otherwise we are going to lose them. With the sepsis or septic shock, organ damage, organ failure, such things. So we need to recognize that first. Many of time, now it is a very common question for the undergraduate examination, exanthematous fever, fever with rash, name 3 causes, name 5 causes, or even 5 marks question. And even very common question asked in the day-to-day practical examination, or whenever you present fever, you need to ask the patient whether he has appreciated rash, because some rashes may be very transient. By the time they have come to your clinic or your hospital, the rash would have already disappeared. So you need to ask whether the transient rash, persistent rash. Okay, now, and what is the pattern of rash? Now I'm going to tell you the differential diagnosis for the fever with rash. Now you all are very familiar. Before developing these vesicles, first day there may be only erythematous macules. We know that that is a varicella zoster. The first slide on the top slide, chicken pox or varicella zoster. The second slide, diffuse rashes, non-pruritic rashes everywhere on the body, starting with the face, trunk, and going down, and so on. The moment you say this kind of rash, we need to think measles. The pathognomonic sign is you need to look on the first 2-3 days. Now, all of these patients would have had fever for 1, 2, 3 days. After 2 to 3 days, these rashes will appear. After 3-4 days sometimes. In rubella, in infectious mononucleosis, even in typhoid fever, they do not recognize rash. Patient may recognize rash, erythema, or rashes somewhere, non-pruritic rashes on the trunk that would have been evaded by the time patient has come. Now, in our community, recognition of rash is with little rash in typhoid fever and rheumatic fever and other things, because our skin color is little darker. So you may not recognize the typhoid rash. The typhus fever, patient may not tell you. You need to talk about the tick bite, history of tick bite, trekking, venturing into the forest, agricultural labor. They neglect because it's a common day-to-day problem to them. Tick bite and small ulcers. We need to look for that eschar, a dark patch and the surrounding erythema and scaling. Eschar, very difficult to take out this dark spot. That is a tick bite. If that mark is there, patient come with the fever, that will be typhus fever. So we need to concentrate on the pattern of rash, day of appearance of rash, distribution of rash, how did it start, how did it progress. Now that is not beyond the scope of this lecture, it will go on with this thing. So we need to look for those things. I have some more slides taken by the textbook. Now this rash, very confluent rash, very patient may be having fever, sometimes even hypothermia, it may be in the extreme shock. That is a fulminant meningococcemia. If you do not recognize this rash, confluent rash, meningococcemic rash, hemorrhagic rash in the early stage, you're going to lose the patient. And the moment you see this rash, even you have to take precaution. You are exposed to this meningococcemia. So you need to take the prophylaxis. Otherwise, even the attender will develop the meningococcemial infection. So you should be extra cautious on that. And sometimes patient may come with this, they may not tell, you should specifically look for the shin. It may not be visible as a erythematous rash. It may be palpable as a painful nodule, as a erythema nodosum, which is very typical in tuberculosis, leprosy, many infectious conditions, which may tell about many chronic infections. And these are some the erythema marginatum. You can see the target type lesion, erythema marginatum, which is typical, which is not very common in our country, which is common in the Lyme's disease. And impetigo, bacterial infections, staphylococcal infection, we can get those kinds of rash, very common in the West. And this kind of rash on the shin, which are palpable, they are typical of vascular, because we are talking about fever with rash. If you feel a palpable rash is there, it may be thrombocytic purpura or vasculitic syndrome, like in primary vasculitis or secondary vasculitis. So you need to consider those set of the disease, non-infectious condition. Then, frankly, I have not seen a case of secondary syphilis or tertiary syphilis, even primary syphilis. So it is very unlikely that you may see this all from the image library. Secondary syphilis rash will appear like this, and which is extinct now. Only a historical aspect. These were the rashes of the smallpox. Just to highlight that. Okay. Now that is about rash. So what is important in the rash? We need to ask or observe for the rash, pattern of rash. You need to ask which day of the fever it has come, how did it recede, whether vesicles were there, whether the painful nodules were there. All those things you have to take. Okay. Then going with the next common association, fever may be. So now the common thing is arthralgia, painful joints, or arthritis, joint with pain, swelling, redness with the limitation of use. So then we call it arthritis. There are so many conditions which can come, which can you think, hundreds of conditions, but common to us are dengue fever, chikungunya fever, rheumatoid arthritis, arthritis of rheumatoid arthritis, and they may manifest fever, connected, sir. Rheumatic fever, we know the typical fleeting fever, migratory polyarthritis. Last time we have discussed psoriatic arthritis, Still's disease, inflammatory bowel, arthritis with inflammatory bowel disease, or seronegative spondyloarthritis, common in males. So many conditions which can present with arthritis, arthralgia, and fever. So you need to look for the pattern of the joint involvement, whether small joint involvement, large joint involvement, whether the axial joints are involved, whether it is migrating, whether it is persistent, whether skin cutaneous manifestations there. So many things has to be talked about with the fever with the arthralgia and arthritis. Many times fever may present with the jaundice. Patient may come with 2-3 days of fever, and the moment you examine, or patient himself say that I have yellow urine or yellow eyes, or when you examine, there may be jaundice. So it should lead to a diagnostic clue to you. Commonly, the commonest cause is viral hepatitis, hepatitis A, B, C, D, or hepatotropic virus, drug-induced hepatitis, especially drugs and toxins when we talk alcoholic hepatitis. Patient may be on anti-tubercular drugs, INH, rifampicin, methyl dopa. There's so many things which are drugs and toxin which can induce hepatitis, and they can, and even autoimmune hepatitis, even a female, they can present with the jaundice, pruritus, and arthralgia, many things. So hepatitis, leptospirosis, common problem, myalgia, muscle pain, joint pain, and jaundice, yellow urine. Don't forget leptospirosis, seasonal problem, expanded dengue syndrome. Uncomplicated dengue is something, expanded dengue when it is involved the liver, hepatitis, malaria. Don't forget malaria, very common condition. It can present with the hemolytic jaundice, autoimmune hemolytic anemia. Even without all these conditions, simple bacterial infection, when it has gone to severe sepsis, septicemia, that can induce jaundice, hepatopathy. Even septic condition, septic shock, ischemic hepatitis, ischemic damage to the liver, all those things can induce fever with jaundice. So you need to customize to the, or find out what is the nature, what is the condition of the patient, and assume that what could be the reason for the development of jaundice in a febrile patient. That itself is a 1 hour talk. Now I've just highlighted only small things. Now, if the patient has come with the fever and the patient relative says that he is not behaving normal, abnormal behavior, or he has lost consciousness. When we found he is febrile and he has lost consciousness, that may be encephalitis, like common thing, Japanese encephalitis, herpes encephalitis. Okay. Now, encephalopathy, various metabolic parameters, even in heat stroke, they may come with they may be found in a high temperature, body temperature and loss of consciousness, sudden, or sometimes raised intracranial tension due to the intracranial space accumulations. Sometimes intracranial bleed itself, no infection, intracerebral bleed, spontaneous hemorrhage manifests with the unconscious unresponsiveness and high temperature. So are the condition, or immediately after seizure. You know, the seizure is a very convulsive mechanism. Heat production will be there. If you record the patient, as soon as the patient may be having post-ictal confusion, record the temperature, patient will be having fever, altered sensorium. So you may think that it is infectious. It may be simple seizure, idiopathic seizure. He would have had seizure due to the withdrawal of drug. May erroneously lead to the meningitis and other things. So you should be extra cautious on these things. Now, whenever the temperature, now I have told you that we have a robust system of thermostat, thermoregulation, with the intactness of the hypothalamus, with the intactness of the cardiovascular system, adequate volume of the blood, adequate autonomous nervous system. If it is adequate, seldom our temperature raises in spite of any infection. Seldom it rises above 103, 103.8, that is 4.5. The normal temperature is maintained just above 4.5 degree. If you say that 38, 37.5 is the highest normal, 4.5 is 101, 102. Up to that level, in that range, our body, why is our body should maintain the normal temperature? Because beyond that, our metabolic mechanism, cellular metabolic mechanisms, which involve so many enzymes, they become useless. Our metabolic system fails. Oxygen consumption fails. That is why whenever the temperature goes above 104, we assume that his thermoregulatory mechanism has failed. If thermoregulatory mechanism is maintaining properly, that will not allow the temperature, body temperature, to go above 103.5 to 103.8. Okay, so whenever the temperature goes above 104, some books say temperature goes above 106, there is hyperpyrexia or hyperthermia. Technically, is the hyperthermia, technically, is it correct? Our body temperature is set at particular level. Whenever it goes above, we should call it hyperthermia, but we do not call it hyperthermia. 100 degree, 101, 102, we do not call it hyperthermia, because we assume that their thermoregulatory center of the hypothalamus is functioning. So to call it as hyperthermia, they should be absent. The thermoregulatory center is not functioning. Okay, fine. That is inadequate functioning. So whenever temperature more than 104, we call it hyperthermia, and very high, we call it hyperpyrexia. Okay. Now we need to understand two things. Hyperpyrexia and hyperthermia are not synonymous. There are different mechanisms for that. We'll come back to that. Whenever we have temperature more than 104 degree, these are the common condition producing that. Thyroid storm in appropriate setting, known hyperthyroid patient, or you have external features, you can easily diagnose that. Cerebral malaria. All reason, there may be hemorrhage, there may be hypothalamus set point, everything is ongoing thing. Many things are there. Spontaneous hemorrhage. Again, because of the destruction there. Meningitis, atropine toxicity, or heat stroke when you are exposed in the, when you are in the high temperature environment. Environment temperature more than 40 degree, 40, 44. As I said, heat. It is not your thermoregulated center. thermoregulatory center is not, heat dissipation cannot happen. So body retains more and more heat. The thermostat will not sense that. Now, how do you differentiate hyperthermia to hyperpyrexia? They are not absolute, but these are some of the things. Severe, whenever the temperature goes above 104, we assume that it's hyperthermia, but to call it hyperpyrexia, it should be more than 106 degree Fahrenheit. Very severe fever. Still hyperpyrexia, thermoregulatory failure may be cause. But if it is due to infection, it may be due to thermostat, which is set at a very high level. That is, in hyperpyrexia, due to infections, thermostat may be functioning. Thermostat may be set. But in hyperthermia, because of the heat cannot go out, in spite of thalamic center functioning, it cannot evaporate heat. Thermostat failure is there. The set level may be normal. That is the essential difference. Hypothalamic failure results in the hyperthermia. Now, history will be typically environmental exposure, old age, risk factors of old age, a person taking drugs, antidepressant drug, sudden withdrawal of antidepressants, sudden withdrawal of antiparkinson's drugs, or use of serotonergic drugs, okay, or appropriate conditions like bleedings, sudden bleedings, spontaneous hemorrhage, thalamic hemorrhage, such things, intracranial bleeds. Typically, those patients, whenever temperature goes above 104, they will alter the sensorium. Whereas in hyperpyrexia, the infection, they may not alter the infection if there is no central nervous system cause, like CNS bleeds. Okay, fine. Patient may be having some focus of infection, and that temperature would have gone gradually up in such condition, like in cerebral malaria. Now, I've told you that heat cannot evaporate by sweating in hyperthermia. So, periphery is hot and dry. Whereas in hyperpyrexia, when the thermostat is functioning, it makes the peripheral vasodilatation and allows the sweating. Periphery appears cold because of the peripheral vasodilatation. Skin will be cold, clammy, and wet. That is the essence. It is not 100%, but if the temperature is above 104, skin is cold and clammy, it is more likely infectious cause. When the skin temperature is more than 104 degree Fahrenheit and skin is dry and hot, it is most likely due to hyperthermia. Now, there is one more clue. You assume that is hyperthermia, we have missed it. We give antipyretic. In spite of antipyretic drug, appropriate response is not availed within half an hour, 1 hour. You give intravenous paracetamol or oral paracetamol and NSAID, ibuprofen, temperature does not come down. It is hyperthermia, because in hyperthermia, the thermoregulatory center, that prostaglandin mechanism cannot work. So that is another clue. So these are some of the clues to differentiate hyperthermia. We know that hyperthermia, there are so many causes. It may be heat stroke, it may be neuroleptic malignant syndrome, it may be drug-induced like anesthetic agents or serotonergic syndromes. So many things are there. So we need to, because the treatment of those conditions are entirely different. Your antipyretic will not work. Body temperature has gone up very high. If you do not recognize that, it will synthesize in multi-organ failure, because beyond 104, your internal body metabolism cannot function. Body metabolism, energy utilization, production, or anything, oxidative metabolism cannot work. Patient goes for anaerobic hypoxia, ischemia, the peripheral vasodilatation, the shunt, the vascular shunt also happens, splanchnic vasoconstriction, liver, kidneys undergoes hypoxic damage, ischemic damage, and will lead to the multi-organ failure, even the brain death very rapidly within few hours. So it is very essential to recognize whether it is hyperthermic condition or infectious condition, hypothalamic failure or not. Now, very commonly, interestingly, we are hearing the history saying that, sir, my patient has got evening rays of fever. Why is that? Morning time patient is not having, evening patient is having fever. Why? Very common question. We all know that typically tuberculosis will produce that. Similarly, chronic low-grade infection will produce that. Evening rays of temperature. Low-grade tumor also may produce that. Why is that? We know that our body diurnal variation, morning 1 degree less than the evening. Already evening temperature is 1 degree higher. So our body is accustomed to 1.5, 2 degree fluctuations. Say morning, if the temperature has gone up 1 degree, it has not reached 37.8, 38, just 38, 37.5. Patient will not feel because anyway his evening temperature will be that. He's accustomed to that temperature. But that same temperature persists till evening. Evening his normal temperature will be 37.5. Add to that 1 degree, 38.5. That will be appreciated by him. So because of the continuously the pyrogens will be there, just mild fever will be appreciated in the evening hours. So that is one thing. Sometimes some of the pathogens may produce cytokines specifically, like we know that malaria once in 48 hours. Similarly, some of the bacterial cytokine release, like in tuberculosis, may be more in the evening hours. So that is why there are two mechanisms. One is diurnal variation, that persistent fever 1 degree more will be appreciated by the patient easily, or the cytokines will be released in the evening hours, that is producing evening rays of temperature. Very typically similarly, many of the long-standing fever will have the weight loss. Short-lasting fever will not have weight loss. But any person having rapid loss of weight within 1 day, 2 kg loss, 3 days, fever, loss of weight, that is because of the water loss, dehydration. You need to think of hyperthermic condition. Okay? Very typical history. Fever, persistent fever with loss of water will lead loss of fever, especially in athletes or truckers. It may be indicating of hyperthermia, heat stroke, heat exhaustion. Very peculiar to note in acute fever. Chronic fever, we know this hypercatabolic state. But in acute, within 1-2 days, it's not hypercatabolic state. It's because of the water loss. One more common association is sweating, especially night sweat. We call night sweat. Even normally night sweat is more. But in the fever, because of the heat dissipation is there, you will have the sweating, more sweating. They typically drenching night sweat, as if somebody has taken bath. People typically say that, sir, night time, I woke up with the sweating, my banian or shirt or even my bedsheet is wet. Such kind of drenching sweats are very typically seen in tuberculosis, hypercatabolic states, lymphomas or tumors, malignancies, where the heat dissipation is very high because of the cytokines and peripheral vasodilatation. So these are some things you need to specifically look into that. Now we come to the evaluation. We have understood what are the various aspects. Now we have come to the specific point of evaluation of patient with fever. Now it should be, you may not have much time, you may not have much time, you should be tailored and focused. You cannot take every aspect in a 2 days, 3 days history of fever. Quickly you need to detail. History is important with due importance to the rash, urine volume, weight loss, fatigability, pattern of fever. Such things is important. And focused examination is also important. Your examination should be focused to the specific items. Now we all know that I will not go to highlight this duration of fever. When did it start? How did it start? What is the onset? How did it start? Whether it is sudden or gradual. Whenever sudden onset of fever, there will be feeling of chills and shivering. Whenever you say fever with chills and rigors, shivering is there. That says that our thermostat has suddenly changed, making the sudden rise in the body temperature. and then that will be having. Somebody says that fever is there, but I never had chills and rigors. That is usually thermostat has gone up very gradually. There was no immediate necessity for increased heat production. All the things were necessary was decreasing heat dissipation. So the patient will not feel the chills or rigors. Okay. So that is how you recognize by history. Okay. How long did it present? We already discussed it. Is it present only for the few hours of the day or present throughout the day or only at the evening or night? We have just discussed those things. What is the periodicity? Again, we have discussed whether it present few hours of the day, several times, it appears several times a day, or how throughout the day, throughout the night, several days in a row. All those things you need to take the history. How did it recede? Only with the antipyretics or spontaneously? Typically in malaria, even if you do not take drug, within 4 to 5 hours, fever recedes by crisis with profuse sweating, and the fever reappears after 48 hours or after 24 hours or 48 hours. Again, typical pattern, one spike of fever, it comes down without with profuse sweating. In between the fever, patient feels very comfortable. He is not ill at all. That is very typical symptom in a malaria. Okay, I'll come back to the chat box 1 second. Sorry. Okay, in malaria, am I audible? In malaria, fever recedes by crisis. Okay. Why? We all know that the propozoid or the parasite, the fever develops only when the ruptures, the RBCs are rupturing, merozoites are liberating. That occurs simultaneously, periodically. And next 48 hours, they will be in intra-erythrocytic circle. So there is no cytokine release. There is no fever. Okay. We have discussed this very common question. What are the causes for fever with chills and rigor? The moment you say fever, chills and rigor, sudden onset of fever. Common conditions: malaria, urinary tract infection, cholecystitis, pneumonia, and absence. These are the five. There are so many conditions, but these are the must know. These are the anticipated answers from you, from UG student. Everyone. The headache, prostration, general weakness, very common in viral fever. Every fever will be associated with the headache, prostration, general weakness. I've already told you, rash, myalgia, joint pain, joint swelling, all those things. The important history you need to know. We have already understood that what are the things. Then you need to ask about symptoms specific to the system. For example, cough, expectoration, headache, nasal rhinorrhea, vomiting, diarrhea, dysuria, frequency of urine, altered sensorium, so on, which all to localize, which gives the focus of the system involved. Okay. Now again, this is a slide from the Davidson. Very good. How to approach the fever. You get a febrile patient. First, as I said, you need to record the temperature properly with adequate thing. Record his pulse, blood pressure, observe his respiratory rate. Okay. See joint, whether jaundice, very easy to see. Jaundice is there, pallor is there. Any obvious things are there, you recognize. Okay. So those are the general examination, head-to-head exam you can do. Now there are 10 marks there. Now this is what you look at the skin. So this is copied from this textbook. So it says C opposite. You can see in your books. Generalized erythema. We all say, I will already describe what are the things. Look for the rashes, any furuncles, any swellings there, any IV infusion site like thrombophlebitis or IV drug abusers, prosthetic device somewhere, such things you need to, tattooing, such things you need to give importance. Hands and nails, look carefully for clubbing. We know the fever with clubbing, there are so many set causes. Look carefully for the, if you appropriate setting, look carefully for the sphincter, very tiny, you can see the tip of the thing, very classical in the infective endocarditis, Janeway lesions. Other signs of chronic liver disease we have discussed earlier, erythema nodosum, such things, vasculitic lesions, palpable purpura, such things. Look at the oral cavity, look at the paranasal sinuses, look at the oral cavity for the pharyngeal congestion, rashes there, oblique spots, such things you can look for that. Look at the head and neck situation, look for the lymphadenopathy, palpable lymph nodes enlargement, abnormal tympanic membrane, whether there is a perforation, very classical perforation or discharge from the tympanic membrane, fever, headache, it may be brain abscess, very notorious condition. Parotidomegaly or lymphadenopathy, thyroid enlargement, thyroid, tender thyroid, it can tell you about thyroiditis, can present with long days of fever without notice, low-grade fever. Eyes will note a petechiae, subcutaneous hemorrhage, which is very typical in the leptospirosis and expanded dengue syndrome, various hemorrhagic fevers, painful red eyes, uveitis and vasculitis. Okay, there are so many conditions look for the in the eyes. Okay. Similarly, look for the next step immediately. Just lift your the hand. Wow. The next supple and passive flexion. Try for neck stiffness. The presence of neck stiffness in the fever. Again, it's meningitis, photophobia, delirium, focal neurological deficit. If there is anything, you need to go give good concentration on that. Quickly look for the presence of tachycardia, heart murmurs, pericardial rub, such things. If there is some carditis is there, tick-tacking of heart sound is there, quality of heart sound, and murmurs will tell you about infective endocarditis, myocarditis, and such things. Obviously, GA examination, hepatomegaly, splenomegaly, look for ascites, look for renal angle tenderness. Fever with renal angle tenderness, it is pyelonephritis. Fever with hepatomegaly, splenomegaly, hundreds of causes, tons of causes, you will be very commonly asked for that. The surgical drainage, colostomy, everything you have to observe very quickly. Joint swelling, tenderness, muscle tenderness, very specifically, especially in this viral fever, dengue, chikungunya, myositis, many things you can look for that, musculoskeletal, sometimes draining sinuses, so on. You can further you can ask look for genital area, testes, and PR examination, prostatic examination. Sometimes the fever, dysuria, frequency of urine. If you do the prostatic examination, prostate may be tender. Very often missed. Tender prostatitis presenting as a prolonged fever. So you need to. So this is the page from the nutshell. You can go through that. Now, whenever a patient has got fever due to infection and there is some organ dysfunction, we call it a sepsis syndrome. Sepsis. Okay. Now, this sepsis is an ongoing process. If you do not recognize and stop it, it may halt naturally or it may progress to damage the organ, dysfunction the organ, and cause various other conditions. So it is a disease continuum. We need to break this cascade at the earliest to save the life. So all our role is to identify the cause of fever, correct that, and prevent the complication. I'll come back to that a little later. Now, what is SIRS? I have told you that fever is our response of our body immune mechanism, cytokine mechanism to an invader. So it is a systemic, our system is giving an inflammatory response to an offender. Okay. Now it may be to the internal offender or external offender, doesn't matter. That is internal pathogen, external pathogen. Now, any person who has got temperature more than 38.5 degrees centigrade, when the heartbeat is more than 90 beats per minute, respiratory rate more than 20, or total WBC count more than 12 or less than 4,000 cells, all these things are patient is said that our body is said to be in the SIRS mode. Our body is responding systemically in an inflammatory way. Okay. Now, few years ago, any person who has got more of the temperature and heartbeat, if it is presumed to be infectious origin or documented infection, that is called a sepsis. Currently, there are some other things. Sepsis means SIRS plus suspected or confirmed infection. Suppose patient has got fever of 100, 101 degree Fahrenheit, heart rate of 100, and there is pharyngitis, purulent, that is sepsis. Okay. Or dysuria, assume that it is urinary tract infection, that is also urinary sepsis. But now there is some. When do you call sepsis is very severe? Sepsis with at least one sign of the organ hyperperfusion or dysfunction. I'll come back to that. Now, currently, sepsis is said when there is a life-threatening organ dysfunction or dysregulation of host response to the infection. This is the current definition of the sepsis. Anything is okay for you. So, all those things occurs in a patient with infection, organ dysregulation due to infection. This is not purely fever, but I must tell this thing, because if you do not recognize fever, the cause of fever on the day 1 or day 2, on first week, the patient will go to this syndrome and we will lose the patient. That is what is happening. Now, it is always important to recognize the cause first, treat, prevent complication, rather than pushing the patient into complicated state, pushing him into the ICU, putting him on multiple antibiotics and so on. Now, septic shock is a condition where there is mean arterial pressure is less than 60, or there is a need to the pressure to maintain the BP even after the adequate perfusion. So on. Severe sepsis, infection with organ dysfunction and hypotension. Severe septic shock, very difficult to manage. Now, we'll stop at that. If you do not treat the septic shock, what will happen? Multi-organ failure and death is imminent. So we need to prevent these things by recognizing because I've told you that 60% of the thing of fever is due to infection. We should not allow the patient to go to the organ dysfunction stage. That is the importance of your and my role. Now, course of any infection, fever producing infection, many things may be viral, simple, like the current situation, COVID, they say that 90% is self-limiting. Influenza, self-limiting. Nothing need to be done. Self-limiting. Sometimes it may be protracting. Even dengue is self-limiting. But sometimes it can lead to the protracting complications. People may give natural course, it may be protracting or complicating course. Like in dengue, it can go so the platelet dysfunction or platelet failure leading to the bleeding. Or without knowing that it's dengue, somebody would have given ibuprofen. What will happen? Platelet count is already low. If you give anti-inflammatory drug, it can further block the platelet function and patient can go for the various complications, more complication. Sometimes it delay in the presentation. Patient feels that I am fine, 2 days fever, mild fever, and patient can assume that it is received, or we may miss the diagnosis. So medical care seeking may be delayed, or proper medical care is not given at initial time, so they can go for the complicating course. Then it can lead to the organ environment damage, failure, shock, and death. So this is what I'm highlighting, repeating, stressing. Even the topic is fever, we need to prevent this. Now, how do you recognize that patient is having organ dysfunction? Clinically, can we recognize in a patient with fever? Yes, there is a simple score. SOFA score, sequential organ failure assessment score, organ dysfunction assessment score. Okay. Now, there is something called as quick SOFA that is to be used in an outpatient setting, out of the ICU. Any patient high fever, respiratory rate more than 22, you need to think in the OPD itself. Any patient blood pressure, systolic blood pressure less than 100, you need to think that patient going for the complication. Very important clue, tachycardia, impending shock, or hypotension. 100 is not yet hypotension to be called as hypotension, but systolic blood pressure less than 100, or altered sense. Any of these things, presence of any of these things should herald us that patient is going for organ dysfunction, severe sepsis, or he may be going for septic shock, we need to intervene, hospitalize him and treat him, evaluate and treat him. Now, this is not very important, but still I will highlight briefly. In a patient who is stable in OPD setup, you can treat with the various anti drugs, antibiotics, antivirals. Many drugs are available, which is not very useful in this settings. You can go ahead without any treatment. But one thing I would like to highlight is, many often in the OPD practice or IPD practice, without having proper diagnosis, many of us tend to give quinolone group of drugs, ciprofloxacin, ofloxacin, levofloxacin. Because it's a broad spectrum antibiotic, it acts at respiratory level, it acts at soft tissue level, it acts at the urinary tract. Even without diagnosing, we give them. That should be abandoned. Why? Because in our country, tuberculosis is very common. These drugs are good anti-tubercular drug as well. If you give these things, they will mask tuberculosis. For that reason, unless you diagnose a specific condition, you should avoid levoflox, whatever the fluoxetinolones. Okay. Malaria, of course, these are not very mandatory now. Now, do we need investigation? I'll come back to that. There is one set of fever when the fever is more than 3 weeks. Need not be every day, more than 2 occasions of more than 38 degrees Fahrenheit. On more than 2 occasions, illness is more than 3 weeks, not a known immunocompromised state. And in spite of reasonable evaluation, clinic history taking, clinical examination, and reasonable investigation. What are the reasonable investigation? Basic CBC, urine analysis, basic chest X-ray, few blood culture, urine cultures, ultrasound, thyroid function test, testing for the connectivity disorder. So such things has to be done before saying that pyrexia of unknown origin. Okay, fine. Sometimes fever may, in spite of anything, you may not get any cause at all, whether it is acute fever or chronic fever. We may have to suspect fictitious fever to gain some attention, maybe drug-induced fever. So such patients, this is again for the Davidson, patient may look well in spite of fever of 101 degree, patient may, or when the patient brings the temperature chart, it may look bizarre temperature chart. Temperature more than 41 degrees temperature, but patient is fine. Absence of sweating during temperature defervescence. Normal C-reactive protein, I'll come back to that later. Evidence of self-injection or self-harm. So such things should favor the fictitious fever. Okay, fine. Now, this is again a slide from the WHO. Fever demonstrated rise of temperature should be more than 99. That means more than 100 degrees temperature should be there to call it as a fever. Documentation should be there. How do you approach? A clinical feature suggestive of severity, altered sensory, that is what fixed so far, tachypnea, hypotension, sepsis, urgent management is required, urgent evaluation management is required. If there is a feature of localization, like we have discussed already, manage accordingly, evaluate and manage accordingly. If there is exanthematous fever, that is rashes, evaluate for that, which type of rash, what is the problem, you need to evaluate. Then, if there is a icterus, we have already evaluated, we have already highlighted what are the causes for the fever with jaundice. Go in that line, whether malaria, hepatitis, leptospirosis, drug-induced hepatitis, hemolysis, such conditions. If not, it doesn't fit into any of these things. It may be acute undifferentiated fever. In such condition, two common things, you need to do the rapid diagnostic test for the dengue and malaria. Both are mandatory. all over the world. That is the WHO recommendation. If they are negative, then it is called as acute undifferentiated fever. We will have to symptomatically treat, observe, tell the patient the heralding sign, report back immediately. If the fever persists beyond certain period, say 4 or 5 days, reevaluate, including diagnostic tests for the malaria and dengue. That is the algorithm. Now, so what is the step care in the acute febrile illness? Assess the severity symptom, recognize sepsis. You have to use the clinical tool to assess the localization fever, very important. All your examination part is very important. You can use paracetamol and hydration very frequently. All fever with less than 3 days, there is no specific diagnosis. You should not initiate an antibiotic or any specific therapy. Only hydration, because we know that for thermoregulation, fluid is required, blood volume is required. There is excessive sweating, blood volume loss is there. So adequate hydration, at least 2 to 3 liters of fluid. We all know that along with the fever, patient will have dislike to. So we ask them to take some hot water or something like that. Modify the taste and ask them to take. That itself will give the good energy to the patient, prevent the many complications. Rapid diagnostics for the malaria and dengue are required. More investigations and management if the fever persists. Okay. Then, should we go ahead? Do we have time? Hello?
Yes, sir. We can go ahead with the case.
I have some not true case. I have some hypothetical cases.
Yes, sir. Yes, sir. We can have the cases, sir.
Okay. Now, yeah. Now the case, I myself will read this. 25-year-old male or gentleman office worker, previously healthy, presenting with fever with chills of 4 days duration. Has severe headache and backache. Also having cold, running nose. Got dry cough, no dyspnea. And other symptoms like diarrhea, vomiting, ulceration, nothing is there. Now, what else is required now? The current state, travel history, any fever, travel history to the endemic area is required. The current state, we know the pandemic, travel history, contact history, similarities in the family members or anyone contacts is very important. Okay. So, what will be the probable diagnosis? Now, currently, 1 week fever with cough, myalgia, we call this an influenza-like illness. It may be flu, it may be seasonal flu, it may be H1N1, it may be COVID, anything. So, do we need to concentrate the examination? Of course, as I said, temperature, pulse, rashes, respiratory rate, the three SOFA, quick SOFA has to be done. Then we need to say whether the patient is stable or going for complications. It can go at any day, right from the day 1 or day 2, it can go. Do we need an investigation for such patient? Fever is only 2 to 3 days. Generally, we do not require any investigation such patients. If at all required, we need only rapid diagnostic tests. Dengue, malaria, that can become positive. Other things will not become positive. Or if you are doing any investigations, we need to do the investigations to find out the effects of the fever. Like total leukocyte count, either it will go very high or very low, less than the CIRS, the response is more than 12,000 or less than 4,000. If that category is there. ESR, C-reactive protein, they're all acute phase reactants. Acute phase reactant. Okay, that can tell you that there is something going on. Heat shock protein is liberating, something like that. So you can do that. You can do simple AST, ALT level, SCPT, SUOT level, saying that liver is functioning well, hepatocytes are functioning well. You can do simple urine examination, saying that urine there is no pus cells, no RBCs, kidneys are fine. You can do a simple creatinine, saying that renal functions are fine. So those things are required for a patient who is having more than 4 or 5 days or 1 week. saying that the organs, major organs are not involved in addition to your clinical examination. Otherwise, 1, 2, 3 days fever, none of the investigation will help. What advice do we give? I have already told you. We need to give plenty of fluid, liberal paracetamol. And we need to tell the patient about probable complications. They need to report us back. Okay, this is very simple day-to-day clinical problem. It is not for the exam purpose, but these are for the even if you develop fever. Now, currently, if you develop 2 to 3 days fever, you need to go to a fever clinic where every nook and corner fever clinic is established. Let's go there. Only some such simple cases, not exotic cases, very simple day-to-day common cases only I have put. Now here, 35-year-old, slightly middle-aged, agricultural labor, previously healthy, no comorbidity, present with fever chills of 2 days, only 2 days. Severe retroorbital pain. His history typical say he has come in 2 days of fever. Why? Because he got unbearable retroorbital pain. He is unable to sleep. But severe backache, severe myalgia, but no cold running nose, no vomiting diarrhea, no symptoms to point respiratory, genitourinary, gastrointestinal system involvement. When you see the patient, eyes are congested, red, blanched. When you put a finger, the skin is red, it blanches for more than 3 seconds. And Hess test is negative or positive. I cannot see that, whatever it is. So we know that the diagnosis probably we are talking about such a retroorbital pain commonly comes in dengue fever. Why do I say uncomplicated? Is it complicated or uncomplicated? Only 2 days. It should be uncomplicated dengue. If it's complicated dengue, he should present it with the bleedings, or at least test the tourniquet should be positive, or he should have tender hepatomegaly. He should have more symptoms. It is uncomplicated dengue. Very common presentation in the day-to-day OPD practice. Do we need investigation? Yes, we do. We need investigation to find out his platelet level, to look at his CRP, C-reactive protein, to look at his hepatic involvement. So some investigation are required. Or you can postpone for another 2 days. What do we give? Good hydration, paracetamol, nothing else. Probable complication, he can go for the low platelet bleedings. He can even go for the respiratory distress syndrome. He can go for encephalopathy. He can go for myositis, GPS. Many complications are possible, but we need to keep in mind. But we cannot make the patient anxious about these things. We should be cautious on the probable complication as well. But what should not be done? Such patient, we should not give, I already told you, give aspirin, diclofenac, ibuprofen, or steroid to such patient, because they all block the platelet function, platelet activation are blocked. If the suppose by the 1 week, 3-4 days of fever will come down within a day, but 3rd day, 4th day, platelets starts receding to 20,000 level. Only 20,000 places are remaining, but because of your anti-inflammatory drugs, the platelets are not functioning. They will manifest with severe bleeding. So, in undifferentiated fever or dengue fever, most of the fevers, please avoid giving diclofenac, ibuprofen. Okay. Now, next thing, this 45-year-old male has got fever of 1 week, 3-4 days duration, severe retroorbital pain, backache, like your dengue, previous case, no cough, cold and running nose may be there, may not be there, whatever it is, vomiting, diarrhea, dyspepsia is there, not able to urine. He says that urine is high colored. Say quantity is good. And when you examine, he has got subconjunctival hemorrhage, and his liver is enlarged or tender, and his muscles are tender. This very classical case in leptospirosis, in a season, or complicated dengue, both, and even in malaria. These are the complicated malaria. These are the common presentations. Complicated malaria, complicated dengue, leptospirosis. It's very hard to, very difficult to differentiate clinically. There are some points. I'm not going to highlight on that now. Do we need investigation? Absolutely, we need investigations. We need the hematocrit, we need the CBC, we need the platelet count, we need the urine examination, renal functions, bilirubin, HCP. Everything is equal, but should be focused. Saying that we should not everything. We should be focused and investigate for leptospirosis, dengue, and malaria are mandatory for such patients. And look for the organ involved. Which organ is involved? Which organ is dysfunctional? Which organ is failed? We need to know. Things are required. What advice you give? We can both treat the patient as outpatient department, or depending upon the state of the state, fix sofa. We can decide on admission, or we can give the outpatient therapy. Again, such patients, such complicated patients should not, in addition to the ibuprofen, diclofenac, you should also avoid fruits and juices. Why? They are the most likely patient to go for renal failure. So if you give fruits and juices, they may go for hyperkalemia and more complications. So you should avoid such things, especially in a seasonal variation when the urine is red. Because history says urine is red and volume is low. It may be dehydration, anything. But in such condition, if you give fruits and juices, it's very common. Any person who has got fever, instead of drinking plain water, they tend to drink juice, tender coconut water, high potassium content. They can go for the renal, more complicated renal failure. So again, so all those things are same like the previous case. Now here is a patient who is previously healthy with a travel history somewhere to endemic area, coming with fever, chills and rigors for a few hours of the day, alternate days for a past 1 or 2 weeks. As myalgia, headache, discomfort only during fever. Rest of the period he is able to work. Dry cough is there. There may be cold, running nose, anything. No diarrhea, vomiting, no dysuria, nothing to be. Urine clear is quantity is good. So spleen is palpable on your examination. Spleen is palpable. Now that is a clue to say that periodic fever in between patient is fine. That is malaria. So the thing is very similar. All investigations are required and hydration, specific antimalarial therapy is required. Then 18-year-old student has come, previously healthy person with progressive fever throughout the day. So the sick feeling. Now the thing is, previous patient I did not tell, only myalgia, 2 days fever. Now here more than 1 week, sick feeling, myalgia, headache, anorexia, unable to eat. There may be constipation, GI symptoms are there. Dry cough is there, no cold running nose, no vomiting, diarrhea, but constipation may be there, something like that, no dysuria. So now, when you examine, the extremities are cold. The cold in the sense, the extremities are cold, center of the body is warm. No icterus, coated tongue. And further, when you palpate the abdomen, the gurgling sensation in the right iliac fossa. Liver and spleen are the palpable. Hepatosplenomegaly is there. Very classical presentation in enteric fever, not mycoplasma, enteric fever. Centripetal distribution of fever. Just by looking at the patient, very sick looking person, young people, non-ectic patient. In hepatitis also can happen, but ectic will be there. But here, non-ectic patient, central coating of the tongue, very classical. Right iliac fossa tender and gurgle. Why? In the iliac? Because we know the typhlitis, the primary pathology of Peyer's patch infection is there at the terminal ileum, and it produces tenderness and gurgling, boggy feeling. Hepatosplenomegaly we all know. So this is very classical presentation of enteric fever, very commonly kept examination case for you. So you'll be typically asked, what are the signs of enteric fever? And these patients will have relative bradycardia. So investigations, of course, once you suspect, you need to do the difficult test, hydration, hospitalization, severe sepsis, all those complications. Now, another patient works abroad, previously healthy, presenting with the progressive fever for a few hours of the day for several weeks, 5-6 weeks. This was a severe back pain, myalgia, headache, anorexia. He has lost 6 kgs of weight. He has got multiple large joint pains, but able to do the daily activities. No pointers like cough, breathlessness, vomiting, diarrhea, no systemic pointers. His sleep was disturbed and his night sweats. He was evaluated but could not find out the reason over a month. Now, what does it quantify? The fever is more than a month now. He has been evaluated. Cause not found out. This is the category of pyrexia of unknown origin. Pyrexia of unknown origin. So such case you need to give more importance. It may be Mediterranean fever. It may be connective tissue disorder if it is a female, more common. It may be tumor like lymphoma, which commonly masquerades. Or it may be leukemia, low-grade leukemia. So commonly you need to talk about typhoid fever, malaria sometimes missed out, tuberculosis which is missed out, brucellosis which is mixed out. Okay, lymphomas, leukemias, and occult malignancies are usually missed out. That has to be evaluated in a great manner to find out the cause of the fever. Now, to summarize, so I think I have come to the almost end of the thing. Acute febrile illness is very common. Chronic febrile illness is relatively rare. Among acute febrile illness, the commonest mechanism is infection. So we need to concentrate on that first. Detailed history and focused examination is the key. We need to analyze what is the true pattern. Is it true fever or fictitious fever? If it is true fever, what is the pattern without taking antipyretics? Do we really need investigation? If yes, we need to concentrate on the CBC. Various biochemical parameters to look at the organ involvement and organ damage. We may have to do the imaging like chest X-ray, basic chest X-ray, or basic ultrasound of the abdomen. Or if advanced thing is required, CT scan, or sometimes even up to the PET scan may be required. That is at the end stage of the evaluation of the PU. So cultures may be required, urine culture, blood culture, pus culture, sputum culture, so on. Various antigen tests like your NS1 antigen for dengue, or PCR tests like your COVID test now, antibodies like a malaria antibody test, or typhoid antibody test, so on, or sometimes biopsy may be required. So that has to be customized, tailored to the patient. Not every patient will order every list of investigation which available in the lab. Now, what I suggest is that to find out whether it's a acute inflammatory reaction is there, sepsis is there, or something is going on, inflammatory markers, the best thing is C-reactive protein or ESR. Procalcitonin C, not for the outpatient in a hospital patient to look at the sepsis level, or lactate. They're all for the advanced testing. Now, C-reactive protein, basic, that is acute phase reaction. Whenever there is acute inflammation, the phase reaction, the mediators are increasing. ESR is going up. So this is very useful to say that there is infection. Recognize the sepsis early. Is there organ damage has to be recognized early and to determine the severity. Advise good hydration and liberal paracetamol is allowed for everyone. No NSAID or steroid for simple fevers for the benefit of fever residents. We need to give the caution to the patient and ask them to observe themselves about the warning symptoms of progression of the fever. Patient will definitely come if they have fever, but they may not note the urine color. Dehydration or renal failure produce high colored urine, or nocturnal headache. They may think that is common. And prompt approach is required. Not only approach, attempt is needed from our side to prevent and manage the fever, to prevent the organ damage, and to save the life. Fever is a simple thing, but if you neglect the fever in the first stage, it is a spiraling cascade of the inflammatory response. If you neglect, if you do not recognize early, that patient can go into very serious condition, even lose the life. Okay, simple dengue fever, simple malaria fever, simple typhoid fever, simple staphylococcal infection, simple streptococcal infection, simple UTI. All these things can, if not treated, if not recognized and treated at early stage, that can spread like a wildfire, and that will go for the multiple organ damage. So patient has to be put in the ICU several days, on ventilator for several days, inotropic supports for several days to revive them there. So simple 100, 200 rupees of fever treatment, proper recognition and treatment, missed, going for lakhs of rupees spending from the patient side. And even sometimes even the loss of life. That should not happen. That is only purpose of recognizing the pattern of fever, identifying fever. So that is about identifying the fever. And thank you, everyone. If there is any questions, I would like to take if the time permits.
Yes, sir. Thank you, sir, for the session.
I think it
Sir,
is a session quite lengthy. Okay,
sir,
anyway. Yes. If there are any questions, you can put on the chat box. Otherwise, we'll wind up because I'm almost nearing the end. Dr. Asray, we will stop it. We'll end it. Thank you so
yes,
much.
sir. Yes, sir. Okay, sir. Thank you so
Thank
much,
you
sir.
so much.
Thank you, sir.
Of course, I could not interact with the people like you
It's
had done.
okay, sir. We'll send the chat session, sir. Chat
Okay.
download it.
Okay, fine. Right,
Yes,
right.
sir. Thank you so much, sir.
Right. Thank you so much for stopping it now. Right. Thank you.